Welcome to the deep dive. Today we are buckling up for a pretty rapid, high-stakes journey into a really critical medical topic, transient ischemic attack, or TIA.
hmm
You, our brilliant listener, you actually handed us a set of MSRA revision notes specifically on TIA.
Ah,
And our mission, it's simple but vital. Crack open those notes, pull out the absolute non-negotiables,
mhm.
and turn them into memorable, actionable knowledge.
Exactly.
Think of this as your shortcut to being sharp on TIA, whether you're revising or just want to understand this crucial warning sign inside and out.
And TIA truly is one of those topics you have to nail. It's high yield for exams like the MSRA because, frankly, it's high yield in real clinical practice.
Right.
It's often the body's sort of last warning before something potentially catastrophic happens.
Wow.
So taking these notes and, distilling them into clear, unforgettable points isn't just academic. It's really about patient safety. Let's make sure the absolute essentials from these notes stick with you.
All right, let's start right at the beginning then. The notes define TIA as a mini stroke. What's the fundamental concept? What makes it a TIA and not a full-blown stroke?
The absolute core idea, and it's highlighted clearly in the notes, is temporariness.
Temporariness. Okay.
TIA is sudden neurological dysfunction caused by a brief interruption of blood flow
Mhm.
to a part of the brain, or maybe the retina. You get symptoms that look exactly like a stroke: sudden weakness, vision problems, speech difficulty,
But they go away.
but they resolve. Exactly.
And how temporary are we talking? Is there a strict cutoff?
Well, the notes specify they typically last under 24 hours. But
Oh.
here's a key point to remember, for revision. In reality, symptoms very often last much less than that, frequently resolving within, say, 10 to 30 minutes. The cause is usually a small clot or maybe a piece of debris that briefly blocks a blood vessel and, breaks up or moves on.
Mhm.
The fact that symptoms disappear is the defining feature, but the notes are really clear.
Yeah.
It signals a serious underlying problem. Even if symptoms only lasted a minute, it needs urgent attention.
Right.
There's also a sort of modern angle mentioned. Sometimes imaging can actually show a small area of damage even if symptoms were brief, which, blurs the line slightly.
Hmm.
But for exam purposes, temporary symptoms equals TIA. That's the key.
Got it. Sudden stroke-like symptoms that go away completely.
Okay.
Okay. So what actually causes this temporary blockage or reduction in blood flow? Where do these clots or bits of debris come from?
Right. So just like strokes, the main culprits are thrombosis and embolism.
Okay.
Thrombosis is when a clot forms in situ, so right there within a blood vessel supplying the brain,
Hmm.
often due to atherosclerosis, hardening of the arteries.
Right, the plaque buildup. And embolism is the traveler.
Exactly. Embolism is when a clot or maybe a piece of plaque breaks off from somewhere else in the body and travels up to the brain, gets stuck.
And where do they usually come from?
The notes list the common sources, and this is crucial for figuring out the root cause. High on the list are the carotid arteries in the neck plaque buildup. There's a major source.
Okay.
The heart is another huge one, particularly atrial fibrillation, AF, that irregular heart rhythm where blood can pool and clot.
Oh, yes. AF is a big one.
Big one. Valve problems or other cardiac issues can also send MLI. Less commonly, they might come from the vertebrobasilar arteries, the ones at the back of the neck.
Right.
The notes also briefly mention these rare hemodynamic TIAs caused by just overall low blood pressure in someone who already has narrowed vessels. But really, thrombosis and embolism are the big two. And identifying the source, that's what guides treatment.
Okay, so we know what it is and how it can happen. Now, who is sitting in that risk zone? Who are the people most likely to experience a TIA, according to these notes?
Yeah, the notes give a pretty solid list,
Yeah.
much like the stroke risk factors, really. It helps to think of them in groups.
Okay.
First, you've got the metabolic and lifestyle risks. These are big and, importantly, often modifiable. Hypertension, high blood pressure diabetes, hyperlipidemia, high cholesterol smoking, obesity, and a sedentary lifestyle.
The usual suspects for vascular trouble, then.
Precisely. Then you have established cardiovascular disease,
Mm-hmm.
existing heart disease like valvular issues, ischemic heart disease, or AF, which we already mentioned as a source,
Mm-hmm.
and peripheral arterial disease. The notes also add some slightly less common but important ones: polycythemia vera, that's a blood disorder,
Right.
presence of a significant carotid artery occlusion, or hearing a brute, that turbulent sound, over the artery, use of the combined oral contraceptive pill, excess alcohol consumption, and underlying clotting disorders.
Wow, quite a list.
It is. So for revision, mentally grouping them helps.
Yeah.
You've got lifestyle, metabolic, cardiac, and then blood or artery-specific ones. And the key thing, many are things we can actually change.
Right. Address the risk factors to prevent the event. Speaking of the event itself, what's actually happening in the brain during that temporary disruption?
Right.
What's the pathophysiology in simple terms?
Yeah, imagine like a hose supplying water to a garden bed. During a TIA, the flow is briefly reduced or stopped.
Okay.
So for a short time, that part of the brain tissue isn't getting enough oxygen and glucose. This lack of supply means the brain cells just can't function properly, and that causes the temporary neurological symptoms. The notes keep this pretty simple. It's due to transient cerebral ischemia, caused by a small clot or embolism.
So even though it's temporary, it's a real hit to the brain function at that moment.
Exactly. And critically, as the notes imply, it's a warning sign, because that underlying vascular problem that caused the brief hit, it's still there. The system is compromised, and it's prone to another potentially permanent blockage down the line. That's why managing those risk factors and finding the source is so urgent.
Now, this is where clinical practice gets, well, tricky. A lot of conditions can look just like a TIA. What's on the differential diagnosis list in these notes that could potentially fool us?
This is a vital section, especially, for exams, because getting this right is absolutely key in the clinic. The notes list a fair few mimics.
Go on.
You need to think about things that can cause sudden temporary neurological symptoms. So, migraine with aura, especially if it's focal, a seizure, and particularly TODS paralysis afterwards.
It's like paralysis.
Yeah, temporary weakness after a seizure. Also, complex migraine, like hemiplegic migraine, syncope, fainting, though that usually involves loss of consciousness. An intracranial lesion, like a brain tumor or a subdural hematoma, might cause fluctuating symptoms. Giant cell arteritis often presents with sudden visual symptoms. Retinal or vitreous hemorrhage causing visual disturbance. Other focal epileptic seizures, labyrinthine disorders, inner ear problems causing severe vertigo. Transient global amnesia, that sudden memory loss. Psychological disorders, and let's put a big star next to this one. Metabolic disturbance, especially hypoglycemia, low blood sugar.
Hypoglycemia is the classic primary care mimic you must always check, right?
Absolutely. Rule number one, almost. It can perfectly mimic focal neurological symptoms, and it's quickly reversible. The notes also give hints on distinguishing them. I mean, it can be hard to tell TIA from stroke before resolution.
Sure.
You should be wary of calling it a TIA if there was loss of consciousness or a convulsion.
Yeah.
Those point away from typical TIA. TODS paralysis, as I said, is weakness after a seizure. Giant cell arteritis should make you think about headache, jaw claudication, visual symptoms, and checking things like ESR and CRP. Basically, sorting this list out requires a really thorough history and a careful neurological examination.
Okay, let's shift gears slightly and look at the numbers, specifically for the UK population as provided in the notes. What does the epidemiology tell us about TIA?
Well, the notes mention that TIA is likely underdiagnosed, probably because many people might have brief symptoms and just don't seek help.
Yeah, I can imagine.
But estimates suggest around 46,000 TIAs happen annually in the UK. It gets more common as people get older. The estimated rate is about 50 per 100,000 people experiencing a first-ever TIA each year. The notes also mention a slightly higher prevalence in men and individuals of Black Caribbean origin compared to white populations in the UK.
And that critical statistic you mentioned earlier about the link to future stroke, the really sobering one.
Yes, and this is the number that should really underscore the urgency. The notes state that 15% of first stroke victims had a preceding TIA.
15%.
15%. Let that sink in. A TIA isn't just some fleeting event. It's a bright red flag waving frantically. It means a significant number of strokes could potentially be prevented or at least mitigated if the TIA is recognized and acted upon quickly.
So what does that red flag actually look like? If someone presents with symptoms, what might we see? What are the key clinical features?
The presentation is sudden, and it corresponds to the area of the brain that's affected. The notes list the classic stroke-like symptoms: sudden weakness or numbness, typically affecting one side of the face, arm, or leg.
Okay.
Brief loss of vision or blurred vision in one eye, often described as a curtain coming down, that's amaurosis fugax, or sometimes both eyes. Difficulty speaking, which is dysarthria, or difficulty understanding or finding words, aphasia. Sudden loss of balance or coordination ataxia, or maybe severe vertigo. Headache is less common than with some other mimics, but it can sometimes occur.
And the notes are very specific about the initial steps in primary care if someone presents like this. What do you do?
Absolutely. This is crucial practical knowledge. In primary care, if you suspect a TIA, you need to act fast, quite literally. The notes imply the use of the fast mnemonic.
Face, arm, speech time. Yeah.
Exactly. Face drooping, arm weakness, speech difficulty. Time to call emergency services. Although the notes don't spell that explicitly, FAST is the key tool. Beyond that, the notes state primary care responsibilities are: rule out hypoglycemia, immediately check a blood sugar. Essential.
Number one.
Absolutely. Administer aspirin 300 milligrams stat dose if you suspect TIA and there are no contraindications like active bleeding or allergy. Urgently refer these patients to a specialist stroke or TIA service. And importantly, offer secondary prevention advice immediately alongside the aspirin. Things like advice on smoking cessation, diet, exercise, because prevention starts right now.
Okay.
The notes also remind us to take a detailed history, symptom duration, exact nature, and do a full neuro exam, check pulse for AF, check BP, listen for carotid brutes, check peripheral pulses. It's a full workup, quickly.
So after that initial assessment and the urgent referral, what investigations are then needed in secondary care to really pinpoint the cause and the risk?
Right, the notes are clear about investigations, separating them by setting. In primary care, before referral, you'd often do basic bloods: urine glucose, full blood count and ESR, urea and electrolytes, fasting lipids and glucose, liver function tests and thyroid-stimulating hormone, and importantly, an ECG to look for heart rhythm problems like AF.
Makes sense.
They might also consider checking for coagulation disorders if there's something in the history suggesting it.
And then once they get to the specialists, what happens then?
Okay, according to the notes, reflecting RCP and NICE guidelines, the priority is urgent specialist assessment and investigation. This should be within 7 days if the TIA was a while ago, but critically, within 24 hours of symptom onset if the TIA was recent.
24 hours. That's fast.
It has to be. Brain imaging is needed only when necessary, and the notes state a preference for T2-weighted MRI. They mention that diffusion-weighted MRI, DWI, is particularly good at showing subtle ischemic changes. Immediate antithrombotic therapy with aspirin, 300 milligrams, is given unless contraindicated. And specialist review is needed for specific high-risk scenarios like crescendo TIA, that's multiple TIAs in quick succession, or if severe carotid stenosis is suspected or found.
What other tests might the specialist order to dig deeper?
Yeah, to really dig into the cause.
Yeah.
An echocardiogram to look at the heart structure and function. Potentially prolonged cardiac monitoring, like a 24-hour or maybe even a 7-day monitor, to catch proximal AF that might not show up on a single ECG.
Right, intermittent AF.
Exactly. Brain CT or MRI can look for old strokes, other pathologies, and assess blood flow. And very importantly, they will do carotid imaging, usually a Doppler ultrasound, to check for narrowing in the carotid arteries in the neck. The notes emphasize that a CT brain is not routine unless you suspect something else, like a bleed or a tumor. MRI is preferred for detecting subtle ischemia, and that carotid imaging is vital because severe stenosis there is a potentially surgically treatable cause.
Okay, diagnosis made, causes being investigated. What's the definitive management plan moving forward? How do we stop it happening again?
Right, so management starts immediately with that aspirin, 300 milligrams daily if tolerated, as we said, and that urgent specialist assessment within 24 hours of onset. Crucially, the notes explicitly state, following NICE guidance, do not use risk scores like ABCD2 to decide how quickly someone needs to be seen.
Ah, that's interesting. I thought ABCD2 was standard.
It is used to estimate stroke risk after a TIA that's age, blood pressure, clinical features, duration, and diabetes, but NICE says it shouldn't delay the urgent referral for recent events. Everyone needs to be seen quickly. Got it. Once the diagnosis is confirmed, the focus shifts to comprehensive secondary prevention alongside the aspirin, or whatever antiplatelet is chosen.
So what are the key elements of that secondary prevention package?
The notes detail this clearly. Antiplatelet therapy is the cornerstone. Clopidogrel is usually first line after a TIA or a minor stroke. If clopidogrel isn't tolerated, aspirin plus dipyridamole is an alternative. The notes also reference the CHANCE study, mentioning that dual antiplatelet therapy, so aspirin plus clopidogrel, might be considered short-term for very high-risk patients identified early on.
Okay.
Beyond antiplatelets, it's hitting all those risk factors we talked about. Antihypertensive medication for high BP, lipid-modifying therapy, usually a high-intensity statin like atorvastatin, often regardless of the initial cholesterol level. Managing atrial fibrillation properly with anticoagulation like a DOAC or warfarin once you've confirmed there's no brain bleed. And aggressive lifestyle modification, smoking, diet, exercise, rate.
Right. What about surgical intervention? You mentioned the carotids.
Exactly. The notes mention carotid endarterectomy. This is surgery to basically clear out the plaque from the carotid artery. It's considered for patients who've had a TIA or a non-disabling stroke in the carotid territory and have significant narrowing.
Oh, significant.
Specifically, the notes say greater than 70% stenosis according to the ECST criteria, or greater than 50% according to the NASCET criteria. These are just different ways of measuring it. Secondary prevention should start ASAP for these non-disabling cases anyway, but patients who are candidates for this surgery need urgent carotid imaging within 24 hours to help plan the intervention quickly. And for AF patients needing anticoagulation, you start that after imaging rules out any intracranial hemorrhage.
Okay, moving from the purely clinical to the very practical, one thing patients always ask about, and it's covered in the notes, is driving after a TIA. What are the DVLA rules here?
Yeah, this is a really important point to know for real-world practice and for exams, too. The DVLA guidance is specific. If you are a Group 1 driver that's car or motorcycle, you must not drive for 1 month after a TIA.
1 month off.
1 month off, minimum. Your doctor needs to assess you after that month to confirm you've had full recovery and no lasting issues, especially with vision or cognitive function. If you have fully recovered with no lingering problems, you typically do not need to inform the DVLA.
Okay.
However, if you are a Group 2 driver, lorry, or bus strokes, the rules are much stricter. You must inform the DVLA after a TIA, regardless of your recovery. You will face license refusal or revocation for a year, and you'll need specialist assessment to potentially regain it.
Big difference.
Huge difference. And back to Group 1, if symptoms do persist beyond that initial month, you must inform the DVLA then. Following these rules is absolutely essential legally and for the safety of everyone on the road.
Makes complete sense. Finally, what's the outlook after a TIA? What do the notes say about prognosis and potential long-term complications?
Well, the notes circle right back to the fundamental truth. A TIA is a powerful predictor of future stroke. The risk of having a full stroke is significantly increased, particularly in the days and weeks immediately following the TIA, hence all the urgency we've been talking about.
Right.
The notes emphasize the risk is highest in the first month, but remains elevated for up to a year and beyond. Potential long-term complications, if a stroke does occur later, include lasting disability, cognitive impairment, and reduced quality of life.
So that intensive secondary prevention we just discussed is really the absolute key to changing that prognosis, improving those odds.
Absolutely. The notes really reinforce that. The aggressive management of risk factors, controlling BP, managing lipids, treating diabetes and AFs, stopping smoking, promoting a healthy lifestyle, combined with the right antiplatelet or anticoagulant therapy, is what significantly reduces that scary risk of a subsequent stroke. They mention again the ABCD prognostic score can estimate risk, but reiterate NICE guidelines say it should not be used to determine the urgency of referral. The notes list specific factors known to increase stroke risk after TIA: ongoing high BP, dyslipidemia, diabetes, AF, smoking, and especially having another TIA within a week of the first one. Prompt, comprehensive management is the most important factor in improving long-term outcomes. It's all about acting fast and thoroughly. So here's something maybe to think about as we wrap up. Considering that 15% statistic, 15% of people who have a stroke had a TIA first, how does this really change the way we, or perhaps a patient, should perceive any sudden temporary neurological symptom, no matter how brief it seems? It's not just something that, goes away. It's potentially a life-saving window of opportunity.
That's a really profound way to look at it, a critical window. We've really put these MSRA revision notes through the deep dive today, haven't we? Covering TIA from its definition as that temporary warning sign, through its causes, who's at risk, what it looks like clinically, the crucial investigations and urgent management steps, those really important driving rules, and finally, its prognosis. Understanding TIA thoroughly is absolutely fundamental for stroke prevention.
And breaking it down this way, focusing on the key points and their significance, that's exactly the goal of solid revision, isn't it? Making it stick.
It really helps make the information stick. Thank you so much for providing those notes for this deep dive. If you're working towards the MSRA yourself or simply looking to strengthen your medical knowledge, you might find some fantastic resources out there. Definitely check out passmsra.com and also freemsra.com.
Yeah, great resources.
Keep exploring, keep learning.